Good evening, ladies and gentlemen. Thank you for those very kind words of introduction, Professor Ganji. It's been my honor and pleasure to have worked with you. I'm going to just talk about changing our pathways in Angio CT using the Infinix 4D CT. I have just a conflict of interest. I have a trial grant from Toshiba. So the Angio CT was first developed in 1992 in Japan by Professor Farah. And it took 16 years before it actually was installed at Singapore General Hospital, where we had the system installed in 2008. And it actually has revolutionized how we actually practice interventional radiology there. So if you see the evolution of the Angio CT, it was first developed in 1992, where you had a single slice scanner with an image intensifier. And then over the years, it has morphed into this very, very complex and very, very beautiful piece of engineering. And in 2014, you can have either a 60 or a 320 slice dynamic CT, which is in conjunction with a flat panel ceiling-mounted angiographic system. So what is an Angio CT? It's basically a hybrid room which has a CT scanner and an angio system both in the same room, which share the same floating tabletop. And these two machines can either be used in conjunction or they can be used separately, therefore making the room very, very dynamic. So here you can see it is a ceiling-mounted suspended C-arm, which is a flat panel detector. It can do stepping as well as rotational DSA, and it has cone beam facilities. And you can see that this is how the machine actually moves across your room into the dock position. The CT scanner is a 16-slice one, which we have. It's self-propelled multi-slice CT, and it actually has rails on the floor, and the scanner will move on these rails towards the locked tabletop position. You can have different gantry apertures. Ours is a 72 centimeter gantry aperture with a scan range of 180 centimeters, and it is also capable of doing real-time multi-slice fluoroscopy. So you have multiple new iterations of the Angio CT system. You have the Angio with a large bore gantry, which is 90 centimeters. This is very useful when you have very large patients or very obese, and therefore to do intervention, you do need the large bore. You can have Angio with 160 slice multi-slice CT, or you can have it even with the 640 slice CT, which makes perfusion very useful, which is usually of 16 centimeter perfusions that you can do. So this is the room setup. It's got a lot of hardware. You have workstations for your CT, you have a workstation for your Angio. And in addition to having both the CT and the Angio, you have a tabletop which will actually rotate, in which you can also have your ultrasound scanner in. So you've got all imaging modalities within one room. So if you needed to use Angio CT, previously if you didn't have the system, you would have to send the patient from the angiographic suites, transfer them over to the CT scanner, do the scan, put them back on the trolley, bring them back again, and that could take you anywhere from 45 minutes to an hour. With this system, you can actually do the entire thing in only about 5 to 10 minutes, and that's very, very useful. So what I'm going to do in the next 15 minutes is actually to tell you all about what we can use the system for. And the most important bit that we use our system is for liver interventions. We use it for CERT, we use it for TACE, and we use it for complex RFAs. So selective internal radiation therapy, as we all know, is the delivery of yttrium-90 microlabeled microspheres into the hepatic artery, whereby you give high radiation dose to the tumor, keeping the dose to the liver, normal liver very minimal, and you tend to get no dose to the extrahepatic organs. CERT is complex, and CERT is not TACE. This is the most important thing. We need to plan it correctly. We need to understand the anatomy, the flow dynamics, so that you can get the effective best dose to the tumor without any collateral damage. And there's also very close collaboration both with the IRs and the nuclear medicine physicians to get the best result. The hybrid Angio CT is an invaluable tool because with this system we can actually do intra-arterial CT angiography, which has changed the way that we practice CERT. So why do we need intraprocedural CT? One is to help delineate the anatomy, because we know that we need to get complete tumor coverage. Two, to help get the best safety. Can we avoid any hazardous boundaries? And three, for dosimetry planning. So anatomy. We all know that hepatic anatomy is very, very challenging. According to Michael's classification, you have 9 different systems, but if you actually go deeper into hepatic arterial anatomy, there may be 20 different types of normal variants, and it's very difficult to remember this. There are a lot of variables. Furthermore, hepatic arterial flow changes once the patient has had surgery, has had resection, or has had a previous embolization procedure. Furthermore, if you have large tumors, there is parasitization from extrahepatic supply, which we need to find out, and we need to know what the regional flow dynamics are. So this is a classical example where we can just quickly go through the anatomy. You have the left hepatic artery coming off. This is the common hepatic trunk, and this is the middle hepatic artery. The tumor is sitting in the middle lobe, and therefore you can see that this is the middle hepatic artery, but we don't know what this artery is. And if you do an Angio CT, you will see that this actually supplies the stomach. Having seen that, we actually go selectively into this branch, coil it, and this allows for the safe delivery of Y90. So in the workflow of this, we basically do a selective catheter angiography where the catheter is selectively positioned into the artery that you want to image. You do a DSA. Once you've done the DSA, you have to disconnect the angio injector and connect it to the CT injector, which is a special double barrel injector. The C-arm is docked, the gantry is moved into position from the park position to the scan position, and then before you scan, you actually have to review your DSA image because this will tell you what is your flow rate and what is the scan delay that you require so that you get the best concentration of contrast within the tumor as you scan. Once you're ready, you scan, and then you do your 3D VRTs to get the best image possible of the tumor perfusion. So now we know that if you have very large HCCs where you do search, you can get parasitization from all sorts of extrahepatic arteries. These are just a few that we name. So this is a classical example. There's a large right lobe tumor. This is your right hepatic artery, and you think that you've covered the whole tumor. But if you do an ICT, you can see that the entire posterior portion of this tumor is not opacified or is not perfused by the right hepatic artery. And if I actually do the right inferior phrenic artery angiogram, you can see that there's a large parasitization of this vessel. And we can see that almost the entire posterior portion of this tumor is supplied by the inferior phrenic artery. In this case, you know that the top branch actually supplies the diaphragm, so therefore we coil embolized this and then went on to deliver Y90 through the inferior phrenic artery, and we found this very safe. And the reason we found it very safe was we were very confident that we were not going to get any extrahepatic deposition outside the liver because of the Angio CT. And we published this article where we described the safety of yttrium 90 in the inferior phrenic artery in this paper published in JVIR. This is another very important example. This is a patient who has a very large tumor. He was previously treated with TACE. He failed TACE and had progression, and therefore was referred to us for Y90. And you can see that this is a large tumor, has multifocal tumor within the right hepatic artery. This is a right hepatic angiogram, which shows that most of the tumors are supplied by the right hepatic artery. But if you look at this portion of the tumor, it is not supplied by the right hepatic artery, and this portion, which is extrahepatic, actually has no supply. So then you go and do a right renal angiogram, and you can see that on the right renal angiogram there is this very funny looking artery which is supplying the tumor. And this we confirmed by doing an ICTA, in which with the artery in the renal artery we can see that there is significant supply to the tumor in addition to this extrahepatic tumor lesion. But we didn't know where this artery actually came from. We thought it came from the intrarenal supply. But if you do your ICTA, you can then get a vascular roadmap, and with your vitro, you can actually find the origin of this artery very, very easily. And with that help, we can see that actually it arises from the main renal artery, and it is it's the capsular artery, which we then went on to very selectively catheterize, and we bland embolized this branch and coiled embolized this so that we could then get redirection of flow and the yttrium 90 into the tumor, and that's where we got the localization. So with this, with the newer systems, which are the 640 slice CTs, you can actually do perfusional CTs, and this is very important. In patients who've been pre-treated with TACE, you know that it's really difficult to know which part of the tumor is actually getting supply because of the lipid all present. But if you do a perfusion scan, where you can see the mean transit times, it's very useful to tell you what part of the tumor is being supplied. And maybe we need more research into this, because perfusion may be the next thing which will help determine your dosimetry. So similarly, you can do the 4D HCC, which also tells you what the flow into the tumor is and what the flow out of the tumor is. And maybe the flow dynamics will then help us get better dosimetry and better treatment. So now we come to what is the safety of Y90. And we know that we cannot, if you're going to use Y90, you can get no non-target embolization. You need to coil the GDA, the gastric arteries, the falciform arteries, and the cystic arteries. And you need to do you need to protect the gastric arteries, because you know that with Y90, if it does go into the gastric artery, you can get very bad gastric ulcers, which are very difficult to treat. So this is a classical example of a large left lobe tumor, which is sitting here. And you can see that if you just do a diagnostic angiogram, you can miss this supply, which is seen on the ICT of the left accessory gastric artery, which supplies the stomach. We are all very used to seeing CT images, and actually it's very, very easy to pick this up on the CT, whereby you can see that there's stomach supply. We went in selectively into this artery, and when you do the angiogram, you can actually make out that this is the left accessory gastric artery, because you see the early filling of the coronary vein. So we went ahead, coiled this artery, and then post-coiling, we did another ICTA, which shows that there's no longer any filling of the stomach, and therefore it is very, very safe to deliver your Y90. So with this system, you can actually have a newest guidance, which is called as the C-Shore guidance synchronization with the C-arm position. So once you do a CT scan, you can actually see your scanner slice, where you see what you want to see. So if I saw the gastric artery blush, I could just put a marker on that. That would mark the patient position on the skin. And with that, your CT, your fluoroscopy machine, directly goes and docks in that position. So it's very, very useful in terms of ergonomics and flow. And if you move your table position, the CT scanner will follow that. So these are one of the new features on the new machines that you will have. So we know that prophylactic coil embolization, according to the Radioembolization Brachytherapy Oncology Consortium, states that prophylactic coil embolization of extrahepatic arteries is very important to prevent extrahepatic deposition of Y90, and reported embolization rates can be as high as 87%. However, we know that even with this high coiling rate, about 4% patients will get extrahepatic radiation doses. In our practice, we actually don't embolize that much. We embolize very, very minimally, and the reason for that is because we deliver Y90 not through the proper hepatic artery, but always into the selected right and left hepatic arteries. In addition, we always use ICTA before we deliver the Y90 to make sure that we do not get any bowel enhancement. So if we park the microcatheter beyond the extrahepatic supply and we run a scan whereby we don't see any enhancement outside, we're very happy to deliver Y90 there, and we've had no complications so far. So the most important change that has happened with the arterial CT is Y90 dosimetry. There are three very important ways that you can do dosimetry calculations for Y90. They are the empirical, the BSA, or the body surface area, and the partition model. We've taken the partition model one step further by doing artery-specific SPECT-CT partition model, also known as the personalized predictive dosimetry. So in this system, what we do is we do a catheter-directed hepatic angiography, which basically helps us accurate estimation of artery-specific perfused liver volumes. You then do the technetium-99 MA macroaggregate, which will tell you what is the accurate estimation of the tumor to normal liver ratio. And then you do the partition model, which will then give you the radiation pan for each artery which is perfused. So if you look at this artery, look at this tumor, it's a large tumor sitting in segment 4, and it has got 3 arterial supplies coming from the right hepatic, the middle hepatic, and the left hepatic artery. And in each of these, we have done 3 separate ICTAs, one in the right hepatic, one in the left hepatic, and one in the left and in the middle hepatic artery, which then will help you calculate these volumes, that is the perfused territory of each artery, as well as with that, you calculate the tumor territory which is perfused by each artery, and these ICTAs are then transferred onto your SPECT-CT, which will give you the counts. And when you have the counts of the volume, you have the count ratio, which will then give you your normal tumor to normal liver ratios. And this will then go into a very complex program, which I haven't shown here, which is on our website, which will then help you calculate your dosimetric dose. So with this, you come to what is known as multi-subpartition model for more precise targeted radiation delivery. And you know that if you have multifocal HCC, you know that each arterial territory in which the HCC will have a different TNR. In fact, if you have a single tumor which is supplied by 3 different arteries, the TNR for each of these 3 different arteries may not be the same, and they may be different. And therefore, with this system, you can actually calculate your Y90 dose very, very accurately, so you can get the highest dose to the tumor and minimum collateral damage to the liver. So now moving on, how does ICT actually help you with TACE? TACE is called as transarterial chemoembolization, and you can have 2 types of TACE, that is the conventional TACE and the DEP-DOC TACE. So I'm just going to show you one case. This is a 65-year-old Chinese gentleman who is ECOG 0, ADL dependent. He's hepatitis B, and we've been treating him for the past 5 years from 2010. He's had multiple local regional therapies done, and we're keeping him going because he's on the cadaveric liver transplant list, and we'd like to get him to transplantation. So in this scan, which he had recently done, he has 2 small focal lesions within the liver. And you cannot really see them very well. So in our system, we generally tend to do a CT portogram. And the CT portogram is very useful because what it does show you are these very large focal lesions, which are avascular in the portal venous phase, and these are your hepatocellular carcinomas. So if you look at his angiogram, you can see that the arteries are because of so much pre-treatment, there's a lot of narrowing of his blood vessels, and it's really difficult to see where and what to embolize. In addition, we don't know where the tumors are because there's not really very good tumor blush seen. So we went selectively into the left hepatic artery, and you can see that, lo and behold, there is no filling of the caudate lobe. There's no filling of these arteries. So there's no point embolizing the left hepatic artery. So then we went ahead, and we went into this very, very tiny branch, which is actually the caudate lobe supply, and you can actually see that there is blush here. And if you actually do a dual phase ICTA, whereby you do it in the early arterial phase and then do it in the late arterial phase, you can actually see these tumors really, really brightly enhanced with contrast. This significantly increases your confidence of then going in and doing a chemoembolization, because you're sure you're going to get all that lipidol, all that chemotherapeutic drug into these very small, less than 1 centimeter arteries. So this is your Shaw guidance reference slice system, and it's quite useful because if you see a blush present where you think that is tumor and you've done a CT scan, then what you can do is that if you put the cursor on, it will automatically bring up the slice, which will show the blush, and that will help you decide whether your angiographic findings are in concordance with your CT. So with the system, you can also do a post-STACE CT, which is very useful, which will tell you what your lipidol deposition within the tumor is to know that you've got a good result. And this gentleman actually went on further at 1 month post-TT to show that he'd got very good results within the caudate lobe with no recurrence, but he had progressed with other multiple spots within the liver, and we used the CT scanner to then do an RFA at 2 spots and do a percutaneous alcohol ablation to these tumors along the cut surface margin. So now we come to how Angio CT helps in complex RFA, and we know that with RFA you can get a lot of heat sink. And this is a 77-year-old female who had NASH cirrhosis with portal hypertension and varices, and she had a large tumor which was sitting this is one tumor sitting next to her hepatic veins, and then there's this large tumor sitting next to the IVC. And in this patient, we actually put in a large Coda balloon, reduced the flow through the IVC. Under CT scanning, we then put an R needle into the tumor and then treated it and burnt it. And 4 months down the line, we had a very good result with no further recurrence. So having the angio system and the CT together really improves your ability to do very complex intervention with a great deal of ease. So is it only useful in the liver? No, it's very useful in other areas as well. And we use our CT, this system, a lot to do GI bleeds, to do bronchial artery embolizations, basically to see for spinal artery supply, to do complex endoleak embolizations and other embolization procedures, and also to do complex drainages. So this is a case of acute GI bleed. This is a 60-year-old Chinese gentleman who presented with melena. He developed tachycardia. He dropped hemoglobin from 14 to 10. And a CT mesenteric angiogram showed active bleed in the jejunum. And these are the classical images which we see every day in our practice. So he came to us for an angio. And we can see that on this angio, it's really difficult to make out whether there is actually a bleed or not. So we went in from the SMA, went selectively down here. And you think, well, this is a bleed. There's a lot of bowel motion, you're not very sure. You go down a little further, but you still think that this is. So then we did an ICTA, and lo and behold, in the arterial phase, you can see very good arterial enhancement, and extravasation in here. And if you do the delayed phase in the portal venous phase, you can see that there's further accumulation of this contrast within the bowel wall. And hence, we went ahead and embolized just this very tiny branch, sparing the other branches to the GI tract, making embolization very, very accurate and very safe. So this is the other thing which you can do with the perfusion CT, which is the classical three-dimensional features of the angio CT, whereby you can actually see. It's quite difficult when you're scrolling through multiple cross-sectional images, and this will help you to get a very good overall overview. And these are images which you just get off your CT scanner with post-processing. So I'll just present another case and show you how this system is very useful in GI bleeds. We all know that GI bleeds are very episodic. It's extremely frustrating when you can't see an active bleed on DSA because you don't know whether the patient is bleeding, whether you've missed a vessel, or what. So this is a patient who had a hematological malignancy. His CT shows that he's got a bleed, that he's got a bleed within the bowel. You can see there's faint arterial extravasation, and on the portal venous phase, you can see that this contrast keeps enhancing. He came in for an embolization procedure, and you can see that how challenging embolization is. We've given him 20 milligrams of buscopan, but the bowel is moving, he's constantly breathing. We don't have the luxury of getting the anesthetist to come in and tube every patient, so we have to deal with whatever we can. And you really can't see anything much, and you're not very sure. You've done selective gas runs, and you really still can't find anything. And therefore, we ran the ICTA, and this was what we found. We didn't find any active extravasation, so that improved our confidence of saying that there's no active bleed. But what also it did, it showed that there was this large patch or loop of bowel which was abnormal. It had thickened walls, as well as it was brightly enhancing. And this patient actually did bleed and did go to theatre, and they found that there was infiltration of this loop of bowel which was causing him to bleed. So not only did ICTA help us diagnose this patient who had actually had a bowel loop infiltration, but it also told us that there was no further bleeding which did not require us to embolize or do non-target embolization, and it helped our confidence in doing the intervention. So ICT is superior in detecting the region of bleed compared to DSA. It allows better anatomical delineation as there's minimal image degradation from both respiratory and peristaltic motion artifacts. It prevents inadvertent non-target embolization and improves the safety and the precision of embolization. And a negative ICT improves the operator confidence in determining no active bleeding. And it can shorten both your procedure duration and your contrast load. In fact, with our initial experience with ICT with GI bleeds, we've actually changed our workflow. And if the patient comes in, we know that it's an SMA bleed. If on the SMA run, we cannot find the bleed, we actually run an ICTA through the SMA. If we don't see any bleed, we actually stop the procedure and send the patient back. So in this way, we shorten the duration of the procedure, we shorten the amount of contrast that he gets. And my last case is a splenic artery embolization. This is a 60-year-old female who had severe rheumatoid arthritis on long-term steroid and methotrexate. She developed severe pancreatitis and sepsis. She was in the ICU, and her percutaneous pancreatic drain suddenly started exuding a lot of bloody fluid. So she had an IVCT done, which showed potentially that there is this little spot, which could be a splenic artery pseudoaneurysm. So we did a selective splenic artery angiogram, but we couldn't see anything. So then we ran the CT, and in ICTA, we could actually see this aneurysm sitting off the splenic artery, which was supplied by these very fine branches of the splenic artery. It's really, really difficult to see. So we went ahead and went really super selective, and you can see that this is the aneurysm filling. It's fed by these very, very tiny branches, and it's really very difficult to cannulate these arteries. If we had to treat this, we would actually, it's not point giving glue because it's all going to efflux out into your main splenic artery. Can we use coils? We can't, because then we're going to lose the main splenic artery. So what we did was we actually injected Lipiodol to mark this, the aneurysm. So the Lipiodol went and sat in the aneurysm, and this is what you can see on the CT. So with the aneurysm marked with Lipiodol, we then came percutaneously with a 22-gauge Sheba needle, hit the aneurysm sac, and then under fluoroscopy, we then saw our needle within the aneurysm sac. We injected a little bit of contrast to make sure that we were in the sac, and then glue embolized it. And the final angiogram on the we showed that we had a patent splenic artery. And this way, we actually thought out of the box and did a splenic artery embolization. So with this is a new system which you have the synchronization with CT gantry. If you see a spot that you need, you just mark it on the fluoroscopy, and the machine would automatically go and position your CT scan to that position, and you can get a very good series of images, just like your CT fluoroscopy, exactly in position. So if you compare Angio CT, and we all know that whatever we can do with the Angio CT, we can even do with the cone beam CT. So how do the two systems compare? Because we have both these systems in our labs. And we found that with Angio CT, the preparation is faster, it's easier. The field of view is very large, whereas in cone beam CT is limited because of your detector size. In Angio CT, your coverage is very flexible. You can have a long coverage, you can have a short coverage, however you want, whereas with cone beam CT, it's fixed. Isocentering in Angio CT is very easy. Cone beam CT is more difficult to isocenter. However, your injection timing is very, very crucial with the Angio CT. You need to time your injection very correctly, whereas in cone beam CT, it's more forgiving. If you use contrast, you tend to use a little more contrast with the Angio CT as compared to the cone beam CT, but you have much less artifacts as compared to cone beam CT. In cone beam CT, if your patient breathes, you're not going to get a good image. With Angio CT, you can do multiple phases. You can do an arterial phase, a delayed phase, a portal venous phase. Your contrast window is very large. It's very good. And breathing instructions are less important. And you have a very low effective dose. So we did a study in our center whereby we compared the effective doses for 8-second cone beam CT with large volume cone beam CT with multi-detector CT. And we found that with the multi-detector CT, actually, our doses were much lower as compared to the cone beam CT. So you do get some degree of radiation protection in that way. So is Angio CT a useful tool, or is it a very expensive gimmick? Yes, the machine does cost a lot of money. I think it is a very useful tool because it increases the interventional radiologist's confidence, it improves the safety of the procedure, it allows for exquisite anatomical delineation. IRs are more comfortable now interpreting CT images as compared to fluoroscopy images because we're so used to seeing cross-sectional imaging and seeing the finer details. It allows for performance of very complex interventional procedures with ease. And more importantly, it allows us as IRs to think out of the box and develop new treatment strategies and change paradigms of treatment. I'd like to acknowledge the following people who've helped with this presentation, and I thank you for your attention.